Good evening, everyone, and a very warm welcome to all our esteemed speakers, healthcare professionals, patient advocates, policymakers, researchers, and viewers joining us today. This special panel discussion on strengthening breast cancer care pathways, clinical integration, diagnostic capacity, and policy enablement is supported by AMLI. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my privilege to moderate today's discussion. At the outset, I would like to extend my sincere gratitude to our distinguished panel members who have joined us today. So, improving outcome today is not solely dependent on better treatment. It requires seamless collaboration between specialists, high quality diagnostics, evidence based decision making, patient centered care, and supportive health policies that make quality cancer care accessible to every individual, irrespective of where they live. Through today's discussion, we aim to explore three critical pillars that will shape the future of breast cancer management: clinical integration through multidisciplinary care pathways, diagnostic excellence to support precision oncology, policy enablement for sustainable, equitable, and future ready breast cancer care systems. We hope today's discussion will generate meaningful insight and encourage collaborative efforts towards strengthening breast cancer care across India. So, before we begin, it's my privilege and pleasure to introduce our distinguished panelist. Our first expert this evening is Dr. Kripa Bajaj, Senior Consultant Medical Oncology at Omega Hospital, Hyderabad. She'll be joining us shortly. Joining us next is Dr. Ankita Patel, Senior Consultant and Director, Radiation and Medical Oncology at Apex Hospital Cancer Institute, Varanasi. Welcome to the session, Dr. Ankita. Our next panelist is Dr. Amit Jetani, Consultant Medical Oncologist at Century Cancer Hospital, Rajkot. Welcome to the session, Dr. Amit.
Thank you.
Thank you. We are privileged to have Dr. Niranjan, Consultant Medical Oncologist at Apollo Hospitals, Chennai. Welcome to the session, Dr. Niranjan.
Thank you, ma'am.
And finally, we are delighted to welcome Dr. Neeti Lekha Chabra, founder and president of Yes to Life Foundation, a TEDx speaker, and a passionate patient advocate. Welcome to the session, Dr. Neeti.
Thank you.
So, thank you so much. I think with that context setting, we'll start our discussion. And our first discussion focuses on multidisciplinary collaboration. Now, breast cancer care today requires coordinated effort from surgeon, medical oncologist, radiation oncologist, radiologist, pathologist, nurses, rehab specialist, genetic counselor, psychologist, and patient support teams. Now, strengthening these connections is essential for improving patient outcomes. And to discuss this, I would like to begin my first question to you, Dr. Ankita, that every patient's disease biology is unique, making individualized treatment planning increasingly important. So, I would like to ask you that every patient disease biology is different. So how should clinician integrate pathology, imaging, molecular reports, and clinical findings to develop individualized treatment plan?
Thank you for the question. So, first of all, I want to make a point very clear. Two ladies coming to a cancer clinic, breast cancer clinic, same age group, with similar kind of lumps, can be different. So, this difference is because breast, we can consider it as an organ, and there can be 4 or 5 types of disease in breast itself. So that depends. So any patient coming to breast clinic, the prime importance. So normally they feel ki okay, they are coming to the hospital and treatment should be started as early as possible. But practically they should understand, every new patient should understand that proper diagnosis. Now diagnosis means, first, confirmation with biopsy, then the then after biopsy, it's confirmed that it's what kind of cancer it is, whether it is ductal or lobular. We go ahead with IHCs for ER, PR, HER2, Ki67, and PDL1, and BRCA in some cases. So now this is very important test. Now this will categorize patient, whether the patient is hormone responsive, or the patient needs targeted therapy, or the patient, what's the aggressiveness of the cancer. So it depends on the test results. Also, so this is how the tumor is going to behave. The next phase is, or the next step is to see what is the stage of the disease, whether it is localized to breast, or it has spread to axillary lymph node or other regional lymph nodes, or it has spread to other organs like liver or bone or lung. So after categorizing type of cancer, we need to see the stage, which is done by CT or MRI or PET CT. When we have these all information, then it's not a individual consultants or individual specialty decision. The next step is tumor board discussion, wherein a surgeon, medical oncologist, radiation oncologist, radiologist, pathologist, they discuss and plan the case. So I'll go back to the question. When we have entire, like we have all the scans, we have the molecular reports and all the tests required, then we make the plan of the treatment. And this is how the breast cancer should be approached and treated. But the irony is, because we are like in one, in tier 2 cities basically, so many a times, yesterday only I got a patient, she got operated. Biopsy was done. There was no IFC marker, no workup, no investigation, no staging workup was done. So people should understand, taking a week of time or 10 days of time is perfectly okay. Initial workup, initial all the diagnostic, what your oncologist is suggesting is really important to plan the case. Incomplete workup, poor pathology, incomplete staging workup is going to harm the patient in long run. So definitely we have to integrate entire thing and then plan the treatment.
Okay, so if I may ask you that how can institutions standardize this multidisciplinary decision making? Because I see there are a lot of steps. So if you can help us recommend through this platform that how can it be standardized for the correct decision making?
So for breast cancer, it's almost standard only, because the patient may land up in first OBD with radiation oncologists or surgeons or med-onc. So initial investigation, what is required to be done is like it's very consistent and standard. It's biopsy, IHCs, and staging workup. Once the reports are there, we can stage the patient, and then we have to discuss whether to go ahead with neoadjuvant chemotherapy or whether to go ahead with upfront surgery, whether the patient is eligible for BCS or MRM. So once the report is there, it is very important that surgeon should see the patient, medonc should see the patient. So it should be and it is institutional protocol that after the diagnosis is established, all the team members means all the specialty, they should discuss, plan the treatment, and then go ahead. So in most of the established centers, it is actually in place, the process is in place. So most of the places, it's mandatory that surgeon should see the patient before medon go ahead with chemotherapy, neoadjuvant chemotherapy, or plan as per the stage of the patient.
Correct. So thank you so much for putting it across, and I think we are going to deep dive on a lot many topics in the session further. So my next question is to you, Dr. Amit, that effective communication between specialists is equally important in ensuring timely treatment. So how can surgeons, medical oncologists, radiation oncologists, radiologists, and pathologists work together to reduce the treatment delays and improve patient outcomes?
Yeah, first of all, thank you for inviting me. And so, uh, the communication between all the three pillars of the cancer treatment, and plus the supporting the doctors like pathologist and radiologist is very crucial. At initial diagnosis only, the communication between the treating doctor and pathologist is very much important. So pathologist can have a the clinical background, so they can stamp the diagnosis correctly, and it prevent the delays in diagnosis of the biopsy report initially. And same way, communication between the treating doctor and radiologist is also important. So, like if I give example, a patient having breast cancer and having bone pain, and then if doctor talks to radiologist that she's having pain in the leg, having pain in the back, so radiologist typically looks at that part and point out whether there are metastases present or not. Plus, the communication between radiologist and pathologist also equally important, because the many a time pathologists require the radiological picture for stamping the final diagnosis. So that way, this communication breaks the delay in diagnosis. Now, the further communication is required between pathologist, radiologist, and all the three treating doctors, so that can be done usually in multidisciplinary tumor board, what we call MTB, where we all discuss whether what would be the final plan for this patient, whether patient will require initial chemotherapy, whether surgery first, how long chemo will go, and whether the patient will require radiation or not. And in few of the metastatic cases, whether the all the meds, if they are less than 5%, if I say, if all the meds are targetable by radiation oncologist, so altogether we can decide whether to go ahead with curative intent treatment or palliative intent treatment. So best plan can be decided in MTB. So many a time this physical MTB may not be feasible. So we talk on phone also. So that way, MTB is the proper way of dealing and finalizing treatment plan for patient.
Correct. Also, if I may ask you that, I mean, because it is a very rigorous process and it takes a lot of time. So, what are the biggest reason behind treatment delays in breast cancer?
Treatment delays many a time happen from the patient side. I mean, the diagnostic delay may happen from patient side. So many a time patient with initial lump, because of the social stigma, they do not come to the doctor. Uh, and if we say the treatment delay, then it will be rarely from the diagnostic team. Like in biopsy, they are not getting the typical histopathology report, and typical IHC markers are not coming positive. So it is not looking like a classical case. So in dilemma, the biopsy report come late. The further tumor markers come late. From radiological standpoint of view, if because the all the centers are very busy, so many a time they have to have an appointment of PET CT scan, so that delays the starting of the treatment. And the transport of the specimen also takes time. Like if we a patient in the remote area have done biopsy over there, and they send the specimen to the second tier city where biopsy is done, further tumor markers are done over there. So this transport also delays the starting of the treatment.
Correct. So, thank you so much for explaining it to us, and we'll definitely come back to you with some other interesting questions. Now, taking
Sure.
the discussion forward, I think technology is becoming an integral part of modern oncology care. So, my next question is to you, Dr. Niranjan, that as breast cancer treatment becomes increasingly complex, as we have already heard from the other specialists. So, what role can digital health records, AI supported decision tools, and clinical pathways play in improving integrated care?
Okay. Thank you for the question. This is more relevant in the current era. See, 20, 30 years ago, we were all just going ahead with surgery, chemo, radiation, and then hormone therapies for breast tumors. Slowly started the era of targeted therapies and immunotherapies came into picture. And then people started to realize once in a blue moon, like, why am I even giving chemotherapies to every patient? Can we do something like a de-escalation strategy where are we even over-treating many patients? Then people started to develop few tools. For example, one such tool is called Oncotype DX, or another is Mama Print. In terms of an early breast tumors, do they need chemotherapy or can they avoid chemotherapy? Those are the huge advancements that has come in the medical fraternity in the last 10 to 15 years. But on the current rapidly evolving digital era, where people are more keen on how to integrate the AI technology into the healthcare, there are quite a few things that we can do. For example, in from the diagnosis perspective, or for example screening perspective, what we generally ask the women to do is mammograms. Mammogram, there are data and there are studies which are coming up with using artificial intelligence. They're able to pick up more precancerous and early cancerous in the mammogram specimen. So AI can help us to detect more number of patients when compared to the human eye. That is number one. The second thing is, with the electronic digital records, what we have in the hospitals, we can reduce the duplication, we can reduce the human error, and we can have more robust data system which help us to even do more research in future about the patient's conditions. Is there a particular trend of patients who relapse quite in a particular pattern? For example, a particular genetic condition makes the patients relapse earlier. All those informations can be picked up when we maintain a proper electronic digital record. So, and these are the ways probably in which we can integrate the electronic records and the artificial intelligence. And one more important thing, what we might get in future is predicting models. In the general population, if somebody comes random and asks you, what is my risk of getting a breast cancer? We all have a predicted history related tools, but maybe in future with many more information coming along with the help of this electronic records, maybe we can have an AI based predictive model which says what is the likelihood that you might develop a breast tumors in future. That could be a future way forward.
Correct. So, having said and talking about all those digital solutions, so how close are we to implementing these digital oncology pathways routinely across our day-to-day practice in India?
See, incorporating digital, all these artificial intelligence technologies will is not so easy because you need to maintain the patient safety data. So there are stringent guidelines regarding what information of patients you need to give to the AI database. So those are a separate entity that is running in the background. So at this juncture, even any patient walks into OPD will come and ask, sir, I have looked into chat GPT. It says that we need to use this drug. We cannot use this drug. There are so many side effects when I use this regimen. So those are the common patients whom we see day to day in our OPD. So what I would say is we need to use these AI tools with a pinch of salt. Yeah, they are good, but it's garbage in and garbage out. If you feed them wrong informations, probably won't get you. If you won't give the right prompt, then probably the answers would be a bit different. So you need to have the basic knowledge of what the disease is about. So, and then when we have the right question to ask them for a right particular patient, then that would probably be the way forward in future. So the right technology, the right scientific evidence, and the human touch of an experienced multidisciplinary team will be the probable three cornerstone in integrating all these digital platforms.
Correct. So thank you so much. I think now taking the discussion forward, my next question is to you, Dr. Neeti, that beyond tertiary care centers, improving access remains a major challenge. And since you have been in touch directly with a lot of patients and you yourself are a survivor of breast cancer, you can help us understand that what health systems interventions are needed to make multidisciplinary breast cancer care available beyond tertiary hospitals.
Hi, yes. So, see, the idea is not to build a hospital like Tata Memorial or AIMS in every district, but what we can work towards is to bring a change in the health system to bring multidisciplinary decision making closer to the patients. So we have to establish a star like network wherein the district hospitals are able to get access to the expertise of tertiary cancer centers. Now, some of the things that can be done towards this is one, that it starts at primary care level. So I truly believe that the general practitioners or family doctors should be trained to conduct a proper clinical breast examination, and also they should know to correctly direct these patients towards the right next step of screening. Second, I believe that district hospitals should uh, have proper diagnostic services available for timely diagnosis. And also, what can be done is for the general surgeons at this level of hospitals to be trained in performing simpler breast surgeries. Then, these district hospitals should also be able to access closely the expertise of cancer institutes, bigger cancer institutes, tertiary care centers, in terms of having an online tumor board, online consultations, referral pathways. And for this, of course, we need digital integration. And last but not the least would be for PHCs, which are our primary health centers, to have ANMs or ASHA workers trained to become, patient-centric navigators, and also to have trained patient-centered navigators in district hospitals also, because we often see a lot of time lapse between when a person goes to the doctor for the first time till when the treatment starts. So this time duration also needs to be reduced.
Correct. I think you have very well mentioned all the pointers which are required at, apart from tertiary care hospital, whatever are the points which are required at a tier two or tier three level. So I think we'll take the discussion forward, and in our second segment, we will be talking about more towards diagnostics and accurate pathology, imaging, biomarker assessment, molecular diagnostic form the foundation of precision oncology. So we'll be talking about these pointers, and in that direction, my first question is to you, Dr. Ankita, that biomarker testing has transformed breast cancer management currently. So, if I may ask you that how are ER, PR, HER2, KI67 and genomic profiling influencing treatment decisions today? If you can help us understand.
Okay. Thank you for this question. So, first of all, as I mentioned, breast cancer can be of many types depending on ER, PR, HER2, and KI67. So, make stand, I would put it very simply, ER, PR positive cancers, they respond very well to hormonal therapy. So after the mainstream treatment has been done, the patient is with chemotherapy, so the patient is then put
Um,
on hormonal therapy.
Sorry
So
to interrupt, ma'am. There's some disturbance at your end. You're not being able to hear you clearly.
uh, I'm in a silent zone actually.
Maybe.
Maybe some other speaker. Yeah.
Yeah, you can continue.
Should I restart? That's perfectly okay. So ERPR, HER2, and KI67, they forms the pillar of breast cancer treatment. So breast cancer can be of three, four types depending on these biomarkers. So simply putting it forward in a very simple language, ERPR positive tumors, they are hormone responsive. So they respond very well to hormone after the mainstream treatment is done, after chemo and radiation surgery radiation. The patient can be put on depending on the risk factor or hormones for 5 to 10 years, and they are the best performing tumors. Now coming on to HER2 positive, if the tumor is HER2 positive, that makes the cancer more aggressive as compared to ERPR. So maybe a decade back, yeah, HER2 positive meant bad news because the treatment was bit expensive, and not many people had access to anti-HER2 therapies. But now most of the patients are having access, and the patients are really doing well. So if we give anti-HER2 for span of 1 year post treatment, the result is definitely good. Even in metastatic disease with PER2 and TRAS2, the result is really good. Now coming to KI67, KI67, it denotes the how fast the cancer is dividing. So if it is less than, like, say, a 20-15%, the cancer is less aggressive, and if it is more than like 20-25% or 30%, depending on lab cutoff, it becomes more aggressive. So this is very simple conclusion of these tests for the general public to understand. And we cannot start treatment without having these results in hand. So yeah, that is it. So these are definitely very important. And also genomic testing, as the last panelist already mentioned, we are now de-escalating the treatment depending on genomic basically genomic tests like mama print and oncotype dx. If the patient is postmenopausal and very low risk disease, we can uh, avoid chemotherapy in those patients. So definitely these are bare minimum test before starting breast cancer treatment.
Correct. So, according to you, if maybe you can summarize, or if I may ask you that which diagnostics test should become universally accessible to all breast cancer patient across India? What I mean, which are the tests that you would list out?
Very first, very basic, a reliable biopsy report with minimal tap as early as possible so that we don't delay the treatment. Second, definitely ERPR, HER2, KI67, PDL1, and BRCA. Especially BRCA, especially in young females with TNBC. And third would be if HER2 is coming equivocal, then confirmatory FISH test. So these are the very basic but very pertinent tests which should be accessible and with minimal TAT.
Correct. So thank you so much for putting it across. We'll take the discussion forward, and I think advanced imaging technology continue to evolve rapidly these days. So my next question is to you, Dr. Amit, that how should clinician determine the most appropriate imaging modality at different stages of the patient journey?
Right. Yeah. The diagnostic modality has improved. Past, it was just an X-ray, then sonography, then mammography came, then CT, MRI, MRI breast, and then nowadays PET scan is the most recent advancement in diagnosis. So, uh, for appropriateness of the diagnosis, we have clinical guidelines, and we adhere to that. Like in early stage, we require just a mammography, biopsy, uh, minimal imaging like chest X-ray and sonography of the abdomen, pelvis will do, and we can plan the treatment plan with this all investigation only. And for advanced stage, we require PET-CT scan in addition to all this. And if in surveillance, like after completing treatment, there is not necessary to do imaging investigation if patient is not symptomatic. We do basic blood investigation and do minimal imaging every 6 monthly and mammography every yearly. In follow-up, PET scan is also not necessary, so no need to go for PET CT scan repeatedly. This will add more radiation exposure. And in stage 4 disease, if I discuss, the initial PET scan is necessary. Then after having some treatment, the for response evaluation, we can assess with CT scan in between X-ray and USG also. So that way we can minimize the investigation burden over the patient. And that way we can justify the advanced investigation for the patient treatment.
Also, sir, if you can tell me that how can unnecessary investigations be minimized while maintaining the diagnostic accuracy?
Yeah, sure. So that what I mentioned, that better to adhere to the clinical guidelines. There are many guidelines available, like NCC and European guidelines are available. So stage wise, the suggestions are there, and so in the early stage, as I mentioned, PET CT is not necessary, and in screening also. Nowadays, the recommendation is to do yearly mammography, but we can shift to 2 yearly, 3 yearly. The data are evolving that 3 yearly doesn't deteriorate the early detection rate too. And for the borderline suspicious lesion, better to repeat imaging rather than pushing patient for repeated biopsy and so on. And uh, in like in old age, we can minimize the mammography. Like if patient survival is not more than 5 years, then don't do surveillance mammography too. So, staying adherent to clinical guideline makes the minimal use of investigation in patients' treatment for breast cancer.
Correct. So, thank you so much for putting it across. I think it was very insightful. Now, maintaining consistent diagnostic quality remains a challenge because of the diversity that we see in India. So, my next question is to you, Dr. Niranjan, that what are the biggest challenges in ensuring uniform diagnostic quality across urban and rural healthcare facilities?
Okay. See, the main issue is finding the right person to get the scans and the biopsy done, because you can't diagnose and treat a breast cancer without a biopsy. So first and foremost thing in urban areas or in tier 1 or tier 2 cities, where you have facilities for a mammogram being available probably in 1 to 2 hours time, if you look at it in the internet, and when you look in for a biopsy, you can find the person the next day. And it's not about that. If you take it in a rural perspective, it will be quite difficult. So for that, patient needs to travel to quite a major city to get it done. The second thing is not only about the time taken to get the scans, it also depends upon the quality. Okay, we are now living in an era of, for example, in many of the urban centers, we have moved on from doing an conventional mammogram, say 30 years ago. Then we moved on to doing a mammogram plus ultrasound screening. Then the third newer thing is called 3D tomosynthesis. So we have moved on from a different tools which increases the sensitivity rates, but the rural area is still lags behind. That's a difficult thing, and it's very saddening because the patients will not be able to get the same quality. And that is with respect to the early detection part. Now, with respect to the diagnosis part, the previous speakers were mentioning about the ERP or HER2 status. So the main deciding factor in treating any patients of breast tumor is to know what is the subtype of the tumor. You need to have the right quality of testing to categorize the patient. Accordingly, we treat them differently. So if the reagents are not good enough, if they don't give the right results, your treatment is wrong from the day one. So because of all these disparities, This is where probably the AI could help us, wherein you can have telepathology or teleradiology, where you can have the scan centers and biopsies done in the rural areas, and you can have an integration so that they can take good pictures and send it across to the people sitting in the urban areas, and where you can report them and send it back, like what is called like a centralized lab way, wherein you can ensure the standard reporting of the reports and the diagnosis is established wherever the patient is in the country.
Correct. So I think I was going to ask you the same question, and you have already covered it. That what role can telepathology play in improving access? I think you have very well described that having a centralized lab and collecting report across locations can help us make or remove the disparities that we have in the
we
current.
we also need to make sure that the pathologist and the radiologist who are there in the rural areas should continue to get what is called a CME or continuous medical education kind of thing, so that whatever the advancement that are happening should also be shared to the people also. And there should be some kind of a continual training so that the people can, the newer thing comes, they can come update themselves and go back and start practicing. See, how we learn is from the West, so we migrate to the West, learn something, and then come back. Similarly, that can also happen within the country, where there can be annual conferences that are happening where people can upgrade their skills. That's the one another way where we can try to bridge the gap between the different parts of the country.
Correct. I think CMEs, train the trainer modules, and all of these will definitely help us disseminate whatever education one person gets. Now, taking the discussion forward, my next question is to you, Dr. Neeti, that improving access requires strong policy support, and policy reforms are needed to improve the access. Now, my question to you is that what policy reforms are needed to improve these access, affordability, quality assurance for breast cancer diagnostics?
So in breast cancer, the most costly diagnosis is late diagnosis. And the importance of this fact should also reflect in the national policies by extending the financial protection to diagnostic screenings as well, which goes beyond the treatment support. Also, like I mentioned before, that diagnostic services should be decentralized to be present at the district level hospitals as well. And third, something that comes from my own experience of working in this area, I truly believe that no single institution, whether it is a government hospital or national policies or a corporate hospital or NGO, can truly work alone towards bringing down the burden of breast cancer in India. So the NGO that I run, Yes to Life, has been operational since 2014. But for the last 4 years, we have been working under public-private partnership, wherein what we do is that we adopt villages. So in these last 4 years, we have adopted 6 to 7 villages, and we still continue to do with more of these villages. So our team goes into these villages with ASHA workers, and we literally bring the ladies out of their houses to tell them how to do a self-breast exam. We teach them about the changes in the breast that need to be shown to the doctor. We talk about screenings as per age, and we give them pictorial brochures as well. Then we run free of cost OPD for them every week. We have another doctor who goes with us to the community in these villages and slum areas who does clinical breast examinations for asymptomatic women. Any woman who comes to our OPD and who needs any kind of a screening, starting with ultrasound, mammography, to biopsy, PET CT, we provide free of cost screenings to them, because we have coordinated tie-ups with other centers wherein these ladies do not have to pay anything, whether it is OPD or any screening. And then anybody who gets diagnosed with breast cancer, we provide them with financial support for their treatment as well. And we also distribute free of cost prosthesis and mastectomy bras. In addition to this, ever since the NGO started, we have particularly being taking up patients in AIMS who are HER2 positive, and we provide them with pertuzumab, trastuzumab, and other medications that are required because these are not covered, by the hospital, free of cost. So what I am trying to say is that while one single institution cannot take the brunt of the increasing burden of breast cancer, but if we come together, we can work out systems and policies to help us help these patients in a more in a more formal manner. And we do plan to start, and for us at least, this model has worked beautifully to go into deeper, grassroots levels. And we now do plan to start with another such center in another city very soon.
Correct. I think it has very well laid the foundation for our next segment where we'll be talking about policy enablement. So, thank you so much, Dr. Niti, for giving those practical insights and telling us that how you all are supporting on ground um, at the grassroots level. And now, our final discussion is how, at policy, research, innovation, financing, workforce development, and technology can collectively transform breast cancer care in India. So, to take this discussion forward, my first question is to you, Dr. Ankita, that precision oncology is advancing rapidly, and we have been talking across different forums and different formats about precision oncology. So, how can healthcare systems ensure that innovative therapies remain clinically appropriate as well as economically stable, sustainable?
Okay. So, affordability does not means the price tag of the drug. Basically, right treatment given to the right candidate is what required. So that needs accurate test, and that is the most essential, because if we go ahead with cheaper drug with wrong test, definitely that is going to exhaust the patient financially, and the disease is going to come back. So the priority, the concept or the basic idea of precision oncology or precision treatment is to get all the tests. So uh, the availability of the test and the checks of the test and quality assurance of all the test, that should be of top notch quality, and that is what we should first focus on. Now, how we have adopted the precision right now in India, there are major shift going on. For example, coming to radiation, initially we used to give 5 weeks of treatment. It came down to 3 weeks, and now we have adopted 1 week of treatment. So definitely that is going to solve the logistic issues of the patient and financial also, because the patient will go ahead with chemotherapy and surgery, but when once we counsel the patient for radiation, which is going to take weeks, many patients they skip it. So uh, 5 weeks to 1 week, that is the major the adoption which we have done. Secondly, now we have many biosimilar drugs available in India with good results. So definitely that has cut down cost dramatically, and more patients are availing the so-called expensive drugs. And what is important during the treatment is reassessment. We cannot just go on and giving the treatment. We have to reassess the treatment and stop what is not working, especially in metastatic cases. So these three adoption is being followed, and that has made the treatment more affordable in recent days.
Correct. So thank you so much for explaining it to us. Now I think research plays a very vital role in advancing breast cancer care. So my next question is to you, Dr. Amit, that clinical research and real world evidences are becoming increasingly important. So how can India strengthen the participation in breast cancer research and innovation?
For breast cancer research, if we discuss how can we improvise the things in India, And if I start from the top level, then there should be political will to encourage the research in the India. And there should be less stringent process, so more and more companies can do research in India, the multinationals. And not only therapeutic research, there should be more push towards the diagnostic research too, because that is happening less in India. And there should be less stringent protocols also, so more and more patient can be enrolled too. From the and plus there should be some compulsion to pharmaceutical company in India, so they can invest some part of their income into the research. Some compulsion to the doctors and students, so they would be more encouraged toward that. Uh, then we should decentralize the research, and should not be at the first and second tier city only, should be at peripheral level too, so patient don't have to travel too much for the research. And the protocol should be that manner that they visit to the research center should also be reduced, so there should not be more frequent visits. And there are patients uh, have the more fears that in research they will try many unnecessary things to over them, or have a social stigma towards enrolling in the research. So that can be minimized uh, the by social media, by one-to-one interaction, by including healthcare worker who are from their own society, so they can counsel them for enrolling in the research. So that way, patients' participation can also be improvised.
Correct. I think those are very relevant point, and if there's something that you were adding, you can continue.
Uh, yeah, so that way, in the research protocol also, the trial design is more stringent. So the trial patients are not actually the real world patients. The trial patient will not have a dysfunction of the kidney, will not have a dysfunction, mild dysfunction of the liver too. But in the real world, we have patients with very much obesity, with little kidney dysfunction, kidney liver dysfunction, heart dysfunction. So the trial protocol should be little bit liberal to include them also. So many number of the patient can be enrolled in the trials.
Correct. So, thank you so much for putting it across. And I think we have been talking about technology and its adoption for improving the overall breast cancer care pathway. So, my next question is to you, Dr. Niranjan, that looking ahead, what emerging innovations in terms of AI, liquid biopsy, digital pathology, predictive analytics, or personalized medicine will transform breast cancer management over the next decade?
It is not just one, actually, it is about to be a combination of everything. See, the AI is going to be the, you can call like the next game changer maybe, because of it helps us in many ways, wherein we can have an early detection with screening in mammograms, it can help us. And second thing is personalized medicine, as you rightly said. We have mutation analysis quite going on, but unfortunately, there is not enough targetable drugs available for those mutations. In those arenas, the AI can give us a way like what could be the structure of the drug if I am going to block this molecule. So in that way, probably we can think of getting newer drugs quite easily, rather than thinking so much about how complex this could be. So with AI, we are gonna probably see more drugs being discovered for uh, um, undruggable mutations. Number two. Then comes to the digital pathology. Yes, it's going to be the way forward, where you can get a biopsy from one CT and take a picture, share it to the guy sitting on the other end, ask them to report it and bring it back. That's going to maintain your standards. At the same time, it's going to reduce your turnaround time, where you're going to send the sample to the people sitting in the other part of the country and get the reports. So that is three. And the last but not least is liquid biopsy. So, for general population, what is liquid biopsy? In general, we diagnose a disease when we take a sample from the tumor. What if my tumor is not accessible for a biopsy? Or what if my patient says, I don't want to get a biopsy? In that scenario, we draw a blood sample and try to see the cancer cells which are in circulation in the bloodstream and try to extract their DNA and find out the mutation. And for specific mutations, we give them a specific drug. So this is called liquid biopsy. This is an interesting arena. So probably the AI integration and liquid biopsies are going to be the next two major things which I'm going to see in the next decade.
Correct. So thank you so much. We will be having a rapid fire round where we'll ask some more interesting questions. But before that, my next question is to you, Dr. Neeti, to just take a broader national vision. So what should India's long-term roadmap look like to strengthen breast cancer services through policy, financing, or workplace development and innovation?
So, when we talk about strengthening breast cancer services, we are talking about a situation wherein every woman, irrespective of geographical boundaries, socioeconomic status, has access to primary health care. So you asked about touching upon 4 points. So when we talk about policy, I believe that the policy has to be patient centric, that links primary care, district hospitals, and tertiary care centers. When we talk about financing, a good amount of or a good percentage of our budgets have to be moved towards spreading awareness for breast cancer, because that is one way to downstage breast cancer and to reduce the financial burden of breast cancer. And also, like I said before, that the national policy is to include financial protection towards diagnostics alongside of the treatment support. Uh, Workforce development, of course, we need a larger, more multidisciplinary and a more decentralized workforce related to when we're talking about breast cancer, whether it is surgical oncologists or medical oncologists, radiation oncologists, I would say patient navigators or genetic counselors and other counselors, etc. So we have to build capacity at district level hospitals. Very important. I have been talking about this a lot, I know, but this is one thing that I have truly understood by working in this area. Then is innovation. So we cannot see, innovation doesn't always mean to adopt new technologies, but in this case I feel that innovation needs to be adopted to be able to provide more affordable and quality treatment to patients all across, which means making use of virtual tumor boards, telemedicine, using AI, like one of the panelists also talked about using AI before. So using AI for image interpretation, to be able to share your films from mammography, etc., with other, trained radiologists. So these are some of the ways that we can take care of this.
Correct. So thank you so much. And I think this has been a very insightful session. But before we conclude, I would request everybody to turn on your camera, and I'll be just asking one question to each of you in sort of a rapid fire. And I just request you all to be very quick with your answer. It can be one liner or a word. So first to you, Dr. Ankita, that if you could introduce one change in every breast cancer center across India tomorrow, what would it be?
A compulsory multidisciplinary decision before the treatment starts, a digital record of the patient traveling with her, and also a counselor and navigator in each center.
Correct. So thank you so much. To you, Dr. Ankit, that what is one skill? Um, what is one skill every young oncologist should develop beyond clinical knowledge to deliver better breast cancer care?
I feel compassionate care. I mean, all the oncologists are going to have a good knowledge of the medical oncology, surgical oncology, and so on. But the compassion, which is very much necessary in treating the cancer, because you have to understand what patient is feeling, what their family is feeling. So giving compassionate care make it easy for patient and family to navigate through the path. So that is necessary for all young oncologists.
Correct. To you, Dr. Niranjan, that in one sentence, what advice would you give to a woman who has just been diagnosed with breast cancer?
I would say don't worry. It's still treatable and curable in more than 9 out of 10 patients. So all you need to know is don't lose heart. Okay, just a short duration of treatment and you're gonna get over it for sure. That's what I would like to say.
Thank you so much. To you, Dr. Neeti, that what is one misconception about modern breast cancer treatment that still needs to be addressed?
I think a lot of us still feel that cancer is a death sentence. At least in case of breast cancer, it is not. I am a living example of it. The only point that we must always remember is early diagnosis, and so awareness being very important.
Correct. So, with that, I would like to thank all our distinguished experts for sharing such valuable insights and practical guidance. And today's discussion has reinforced that strengthening breast cancer care is not just about introducing newer therapies. It requires coordinated multidisciplinary care, robust diagnostic infrastructure, equitable access to precision medicine, patient centered policies, continuous innovation, and collaboration across every level of healthcare system. So, on behalf of Voice of Healthcare and Amleel, I sincerely thank all our esteemed panelists for joining us today. Thank you so much and have a wonderful evening ahead.
Thank you, everyone.
Thank you.
Thank thank you.
Good night.
Thank you.